Or to cloud. All right, so this morning's lecture, we're going to start into the pediatric or neonate adrenal and urinary systems. So this is going to include the kidneys, bladder, ureters, and the adrenal glands. Pediatric kidneys are, they're one of the more relative easy things to scan. In terms of patient prep, there really isn't too much patient prep. The only thing we really want to try and do, if possible, is to try and fill urinary bladder. Possible. And when we start the exam, I like to begin the exam with images of bladder. So the reason I like to start with the bladder is because, little kids oftentimes can't hold it very well. Newborn babies will just, spontaneously urinate. So as soon as I get the baby up there, I'll take some pictures of the bladder. If it's contracted, it's contracted. I have some images of the bladder contracted. And hopefully by the time I get further down the study and image the kidneys and then come back to the bladder will have distended a little bit more, so I can get some images with the bladder more distended. So I like to begin with the bladder. I will measure bladder wall thickness. That's basically just an anterior to posterior measurement. So it's a AP measurement. So this will give us a good idea if there could potentially be the presence of a bladder wall infection, of cystitis of the bladder. So we're looking for cystitis. So cystitis is inflammation of the bladder wall, which can indicate, possible bladder infection or a UTI. Transducers. Again, I like to start with highest frequency possible. Work your way down. Some labs will have a nice high frequency curve probe. I tend to like those because you get a nice wide field of view. If you don't have a high frequency curve probe, use your high frequency linear probe and just kind of sector it out, vector it out, and just work your way down. If that highest frequency isn't giving you the penetration that you need, then you can switch and adjust accordingly and working your way down to the your typical curve probe. So then after imaging the bladder, you'll move to your typical renal or kidney protocol. Image kidneys using protocol. And windows. So your typical renal protocol, you're gonna have your longitudinal images, you know, lateral, mid, medial, your measurements, put color Doppler, and then you'll do transverse, your transverse sweep, you know, superior to inferior, mid-pole, again, put color on. Do your mid-pole measurement and transverse. We're gonna, you know, also document echogenicity compared to the liver and the spleen. Remember, document echogenicity. So then this is where the protocol tends to differ a little bit. In addition to our typical kidney images we're going to get, we're also going to image adrenal glands. And depending on the patient's age, neonates, and infants, we will kidneys prone position. So we're going to get a couple images of the kidneys from the back. Reason for that is the measurement tends to be a little more accurate when we come from the kidneys from the posterior, from the back. So this is another area where, you know, being a sonographer and thinking quick, you know, if you have a little pediatric kid or a little baby, you know, who's really scared, really terrified, they don't want to let go of mom, they're hugging mom, you can actually do your whole exam from posterior, from the prone position. You know, you can get all the images that you need, you know, and you can just document in your report, you know, images taken from prone position, you know, patient unable to lie supine or cooperate during the exam. So don't be dissuaded, you know, from like, oh, I can't do this test, you know, the baby won't lie down, the baby won't let go of mother. You could do this test with the baby holding on to the mom. So in neonates and infants, we'll image kidneys from prone position. Measurements are more accurate. And another reason for that as well is we could potentially have something called dependent pelvilectasis or dependent dilatation of the renal pelvis. So also might be presence of dependent pelvilectasis. I'm going to go over pelvilectasis a little bit more later, but pelvilectasis is basically dilatation of the renal pelvis. All right. So any of you that have seen neonate and infant kidneys, you know they look a little bit different than your adult kidneys. Normal appearance. First thing we're going to notice with the neonate kidneys is the pyramids are going to be large in comparison with the surrounding cortex. So large pyramids. Compared to cortex. So as the patient or the child starts to grow, the cortex continues to grow as the pyramids become smaller. There's less cortical fat in the neonate and pediatric patients, which also will allow for clear distinction between the cortex and the medulla. So we have large pyramids when compared to the cortex. Pyramids are hypoechoic or anechoic. Anechoic. So in general, when we're describing the overall echogenicity of neonate kidneys, their kidneys are isoechoic or slightly hyperechoic. So they're going to look brighter than liver and spleen. So particularly in the young, neonate newborn babies, those kidneys are going to look hyperechoic compared to the liver. And as the child ages, the renal cortical echogenicity decreases and usually becomes less than the liver by 4 to 6 months of age. So when they're first born, they're isoechoic or slightly hyperechoic to the liver. And as they age by 4 to 6 months, typically it becomes hypoechoic to the liver. Kidneys usually appear populated. Another feature of newborn kidneys. So with neonate kidneys, also the adrenal glands are very pronounced and noticeable. Pronounced. Adrenal. The left adrenal gland actually extends slightly more medial than the right. So left adrenal extends more medial. Right. And adrenals will have a Y or V-shaped appearance. On upper pole of the kidney. So adrenals will appear hypoechoic to kidney with echogenic central stripe. So that echogenic central stripe represents the medullary portion of the adrenal gland. The echogenic stripe is medullary portion of adrenal gland. So as a hypoechoic, a darker cortex, and the echogenic central stripe is the medullary portion of the adrenal gland. So we have liver, our right kidney. You know, we'll notice our pyramids are very large and pronounced. The adrenal gland will be quite large, and you'll see it wrapping around that superior portion of the kidney. So you'll have a thin echogenic stripe and this hyperechoic structure sitting on top of the kidney. Go all the way out. So I've seen adrenal glands that are actually quite long, that extend pretty far down, and it may also come to more of a point. Sometimes you'll get more of a Y shape. So you could potentially get a shape like that. So it's important to image, your adrenal glands, to rule out potential for adrenal neoplasms or masses. Another thing to also note about adrenal glands is if kidney is ectopic, adrenal gland usually remains renal fossa. So what that means, if this kidney isn't in its normal spot, say it's in the pelvis or pelvic kidney, that adrenal gland is typically going to stay in this renal fossa where it should be. The shape will be a little bit different. Typically, it's not going to have that, V or Y shape. But if you see an ectopic kidney, look for the adrenal gland on that ectopic kidney, because more often than not, it's going to remain in that renal fossa. So now you have to go find that adrenal gland where that kidney was, or should be. I apologize. Another thing to remember when measuring kidneys, be no more than 1 centimeter different length. So if you're measuring your kidneys and imaging your kidneys and you get a difference in length greater than 1 centimeter, go back and remeasure. The radiologist is going to ask you to go back, take another measurement, just to verify that there truly is a difference in length greater than 1 centimeter. Because if it's a difference greater than 1 centimeter, that could potentially be an issue that needs to be followed. So when measuring kidneys should be no more than 1 centimeter different in length. Left is typically slightly larger. Right. bladder. So normally the bladder is thin-walled in this distended state and should measure less than 3 millimeters in diameter for wall thickness. So distended bladder wall thickness. Less than 3 millimeters. If contracted, thickness should be less than 5 millimeters. So some congenital urinary tract anomalies. So our first and probably most common is going to be hydronephrosis. You can also have a condition called a patent urachus. And another condition is going to be our multicystic dysplastic kidney disease. Cystic dysplastic kidney disease. So I'll get into those other two a little later. We're going to focus right now on hydronephrosis. So hydronephrosis is dilatation of the urinary collecting system. So causes could be obstruction, reflux, Urine can be backing up through the ureters to the kidneys, abnormal muscle development. Meaning the bladder doesn't function properly or the way it should to excrete the urine, causing backup. And ultrasound is very sensitive in detecting even small amounts of fluid within the renal pelvis. So ultrasound is a good test for assessing for hydronephrosis. So we're going to determine the severity of the hydronephrosis and whether the condition is unilateral or bilateral. Assess severity. Bilateral or uni. Assess ureters. So we're also going to look for hydroureter. Bladder dilatation. So we want to also make sure that this patient doesn't have a very large, overly distended bladder. So a condition called vesico-ureteral reflux, or VUR, is a common obstructive cause of hydronephrosis. So vesico-ureteral reflux. So that's where the ureters connect to the bladder. That's VUR. So this is a common cause of non-obstructive hydronephrosis. Non-obstructive. And this accounts for about a third of all prenatally diagnosed hydronephrosis. So makes up about one third of all prenatally diagnosed hydro. So UVR is an abnormal refluxing of urine from the urinary bladder through the ureters and back up to the kidneys. Here. Normal reflux from bladder through ureters, from bladder or into ureters. So there's 5 grades. Sorry, VUR. So grade 1 is going to be our least severe. And reflux is limited only to ureters. Grade 5 is going to be most severe. And this includes severe dilatation of the ureters and kidneys. Loss capillary impressions. So many cases, often males, and an appreciable number of grades 4 and 5 resolve on their own within the first 2 years. And unilateral and bilateral hydronephrosis may occur, and different sides may have different levels of reflux. So reflux may not necessarily be the same on both sides. One side could potentially be worse than the other. And remember that this VUR typically resolves on their own within the first 2 years. So a good number of cases will resolve on their own within the first 2 years. Some sonographic findings for VUR. Okay. VUR. So you might see hydronephrosis, hydroureter, nephrosis, hydroureter. Ureteral wall thickening. You could potentially see a displaced ureteral jet. So another condition that we could potentially encounter is a uretopelvic junction obstruction. Uretopelvic junction obstruction. So uretopelvic, that's where the ureter connects to the kidneys, whereas a uretovesicular junction is where the ureter connects to the vesicle or the bladder. So we're talking now an obstruction at the renal pelvis. So it's the most common type of obstruction of the upper urinary tract. Most common obstruction of upper urinary tract. And it's most often results from intrinsic narrowing or extrinsic compression at the level of the uretopelvic junction. Results from either intrinsic narrowing or extrinsic outside compression level of UPJ. I'm sorry, UPJ. At uteropelvic junction. So bilateral involvement may occur along with contralateral multicystic dysplastic kidney or vesicular-ureteral reflux. So this condition can often or may also be seen in conjunction with multicystic dysplastic kidney or vesicular-ureteral reflux. Obstruction produces proximal dilatation of the collecting system. And ureter is often normal in caliber, distal to the obstruction. So, proximal dilatation. Collecting system. With normal ureter seen distally. It's associated with increased incidence contralateral, the other side, contralateral abnormalities in the kidney. Contralateral abnormalities in the kidney. So what are we going to see on ultrasound? So this is going to be a kidney. Where we'll see, pelvic calyceal dilatation. So our pelvis and our calyces are going to be dilated, but our ureter will appear normal in caliber. So it's going to look just like it's going to be hydronephrosis without the presence of hydroureter. So when obstruction is pronounced, the dilated renal pelvis extends inferiorly and medially. So you'll have a dilated renal pelvis, dilated calyces, but typically there'll be no ureteral dilatation. If this condition is happening in the presence of also reflux, then you can wind up with hydroureter as well, or even a condition called megaureter. If vesicle reflux also present. Ureter will also be dilated. So another thing to remember also is that ureter can be obstructed anywhere along its path. So that can include also the uretero-vesicular junction as well. Anywhere else along its path and at UVJ. It's that uterovesicular junction. A couple of things that could cause obstruction. So an abscess or lymphoma may cause obstruction of ureter. Or lymphoma. So if the patient has a large abscess and say like the right lower quadrant, you know, maybe they had a ruptured appendix and now they developed an abscess. That abscess could compress the ureter and cause obstruction. The patient has lymphoma and enlarged lymph nodes in the pelvis. Those lymph nodes could potentially be pressing or compressing, causing extrinsic compression on that ureter. Abscess or lymphoma may cause obstruction. An ectopic ureter may be a cause of an obstruction. So that's a ureter that enters the bladder in an improper location. So that ectopic ureter is typically going to be malformed. It's typically going to be smaller than a regular ureter. So that ectopic ureter may be a cause of an obstruction. Ectopic ureter may cause obstruction. On ultrasound, we will look areas of dilatation and narrowing. Try to pinpoint area of obstruction. So we're going to want to see, oh, sorry, bad kidney. So we're going to want to try and visualize, where does that ureter dilate and where does it get narrow again to try and pinpoint that area of obstruction. So we can have we see an area of dilatation in the ureter and then it gets narrow again. We can likely assume where it starts to narrow again is where that area of obstruction is. So as that obstruction gets worse, it's going to dilate more proximally. So eventually, this part of the ureter becomes more dilated. That's a horrible kidney. So we're going to look for areas of dilatation and narrowing to try and pinpoint the area of obstruction. We're also going to try and image increased peristalsis in the distal ureter to the obstruction. So urine's trying to get past, that obstruction, that blockage. The body's going to try and increase peristalsis of that distal portion of the ureter to alleviate the pressure from up there. So it's going to try and get that urine out the best it can by increasing peristalsis of that more distal segment to try and drain out that urine. We're also going to look for or assess urine jets. We're going to look for absence or diminished urine jets. So if we don't visualize a urine jet on one side, that can potentially indicate that there's a complete obstruction of the ureter. And we can also demonstrate, if a urine jet looks diminished compared to the other side, that there's, a stricture or obstruction in that ureter due to that by proving the diminished urine jet. When assessing urine jets, we're also looking for ectopic jets. So also look for ectopic jets. Because then an ectopic jet will indicate the presence of an ectopic ureter. So some other congenital urinary tract anomalies when we're talking about the kidneys. So one thing we could have is a pelvic kidney. These are actually more common than you would think. So if you're doing your ultrasound exam and you don't see a right kidney or you don't see a left kidney, you know, always look in the pelvis for an ectopic kidney or a pelvic kidney. Pelvic kidneys. So this is an ectopic kidney. Another congenital malformation of the kidney is something called a horseshoe kidney. So, right, left kidney. Either upper or lower poles. So this kidney, when you're imaging, like you're trying to get a measurement and it seems like one of the poles just kind of keeps going on and on and on. You can't get a nice border to this kidney. And you're like, hey, what's going on here, you know? And you'll find a little bit of tissue connecting the two kidneys, and it'll connect around posterior or across the back. So you can actually follow that kidney tissue going across the back and connect to the either the upper pole or the lower pole. So typically the two upper poles or the two lower poles would be connected. And you could see that tissue connecting, coming across the back. There could be something called a crossed ectopic. So that's two kidneys on one side. Kidneys, same side. You could also potentially have renal duplication. So that would be a duplicated collecting system. So with a duplicated collecting system, you would have two ureters exiting the kidney, which could potentially come together, say in like the proximal ureter, or you can actually potentially have two ureters connecting into the bladder on that one side. There's another condition called an ectopic uterocele. ectopic uterocele. So ectopic uteroceles, they occur more commonly in females and are more often on the left side. And it results from an ectopic bladder insertion and cystic dilatation of the distal ureter. So it's more common females. Left kidney or left side. So typically your ureters come down and they insert at the base of the bladder. So this would be an ectopic insertion into the bladder, which will result in cystic dilatation of the distal ureter. And is commonly referred to as a double kidney. Not doing it justice. So this ectopic uterocele is seen as a fluid mass within the urinary bladder and is located inframedially to the ureteral insertion of the lower pole of the ureter. Sonographic delineation of upper pole of fluid mass in continuity with the dilated ureter and aforementioned uterocele is a diagnostic entity. So you want to see the upper pole of that fluid-filled mass in continuation with the ureter. So the last one I'm going to talk about today is going to be bladder outlet obstruction. I think it's a good place to leave off. So bladder outlet obstruction. So with bladder outlet obstruction, may be obstructed by a neurogenic bladder, a pelvic mass, or congenital anomaly, such as the posterior urethral valves. So bladder outlet obstruction can be caused by a neurogenic bladder. What that means, a neurogenic bladder, the nerves that innervate the bladder aren't functioning properly and sending the electrical signals and impulses to the bladder to cause it to contract and empty the bladder. This could be due to potentially a mass on the spine or potential nerve damage. So it could be due to neurogenic bladder, it could be due to a pelvic mass, or more commonly, a congenital anomaly, such as a posterior urethral valve obstruction or congenital posterior urethral obstruction. So it's often associated with bilateral hydronephrosis. Associated bilateral hydro. So this posterior urethral valve obstruction. This is going to be the most common cause of bladder outlet obstruction in neonate males. Most common bladder outlet obstruction. Neonate so with this posterior urethral valve obstruction, you might commonly hear this referred to as like a keyhole sign. So when you're imaging your bladder, you'll get a segment of your bladder that looks like this, where the posterior urethral valve will be. So I'm in a transverse view. So this is transverse. I have an image of my bladder. I'm going to see this area of dilatation in the posterior aspect of the bladder where the urethra would insert. And it's going to kind of look like they call it a keyhole. So I mean, I can make this more pronounced. Looks like a keyhole. So this area where you have that posterior urethral valve obstruction may not be necessarily that visible if the bladder is under distended. But if you're able to distend the bladder, it becomes very pronounced. I actually had a patient, he was probably 18 or whatever, and he was always having kidney issues and you know, issues with recurrent hydro, and they couldn't figure out why. And it turned out, you know, he had this issue with the posterior urethral valve that went undiagnosed for a long time. It makes you wonder, like, where he was getting his ultrasounds and his sonograms done. Poor guy, you know, had a lot of issue and damage done to the kidneys from hydronephrosis for all those years of having not had this issue diagnosed. And it's typically diagnosed in the neonate during that neonate period. So some other things that could potentially cause bladder outlet obstruction could potentially be a mass within the bladder. So, mass or tumor in bladder. Can cause outlet obstruction. For bladder outlet obstruction, usually the urinary bladder walls appear thickened and trabeculated. So typically, bladder walls appear thickened and trabeculated. So what trabeculated means is typically your walls are going to be nice and smooth, but a trabeculated bladder wall, you'll see it's going to look rough. And it may only be one side that appears trabeculated. So if I'm in a transverse view, I may only have one wall that potentially looks trabeculated. Or potentially, you know, the entire bladder wall may appear trabeculated. It's going to be irregular and rough. So again, with that posterior urethral valve obstruction, so your transverse view is typically going to look like something like this. If you're in sagittal, it could potentially look something like that. This would be a sag view. Posterior. Urethral valve. Reverse. There we go. Sorry. So there's a condition called prune belly syndrome. Prune belly syndrome. This is a rare congenital anomaly of unknown etiology, affecting predominantly males in 96% of cases, with severe cases resulting in early infant death. And to also include pulmonary hypoplasia related to oligohydramnios in utero. So it includes a triad of hypoplasia or deficiency of the abdominal musculature, urinary tract anomalies, and cryptorchidism. So that would be undescended testicles. Prune belly syndrome. Mainly males. Includes a triad hypoplasia or deficiency in abdominal musculature. Cryptorchidism. And urinary tract anomalies. So this anomaly includes congenital absence or deficiency of abdominal musculature, large hypotonic dilated tortuous ureters, a large bladder, a patent urachus, bilateral cryptokinetism, and a dilated prostatic urethra.